All right, good afternoon again, everyone. Thank you all so much for joining the Center for Equity of Care this afternoon as we recognize National Minority Health Month. My name is Andrea De Loney, and I'm a project manager at the Center for Equity of Care. Thank you for carving out time to join us as we welcome a very special guest, and I am sure that he is no stranger to anyone who works within the health system. We are very excited to have Dr. Raju, Senior Vice President and Community Health Investment Officer, spending time with us this afternoon. Next slide, please. In addition to celebrating and recognizing Minority Health Month, the Center for Equity of Care is excited to celebrate 10 years since being established here at Northwell Health. And our mission is to advance the delivery of culturally inclusive healthcare and effective communication in partnership with our communities to achieve health equity. And as we work daily to do this, especially in the times that we are currently fighting through as a healthcare system, we do this and we serve our communities by addressing racial, ethnic, sex, and gender disparities, by being a trusted partner and fostering a culture of inclusion, empowering all people to be partners in their healthcare management, and implementing an expanded model of healthcare delivery through health literacy, education, and cultural and linguistic competency. And now more than ever, it is critical for all of us as healthcare professionals to really understand not only how Northwell is collecting this information, but also how we are analyzing and publishing the data so that our communities understand how we are best advocating and serving them. Next slide, please. And so we do this under the leadership of Dr. Jennifer Mirez, and the Center for Equity of Care functions off of the 6 pillars that you can see here on your screen. Leadership commitment, working with our leaders across the organization to ensure we have proper governance and infrastructure to lead all of these amazing initiatives. Education and effective communication, understanding the needs of our diverse communities, as well as our internal workforce, and providing training such as unconscious bias and health literacy. Community partnerships, working very closely with our community health colleagues and our community relations teams to ensure that we are fully understanding the needs and desires of our communities. Workforce, for many of you, being members of our Business Employee Resource Group program and serving on various D&I committees and task forces. Supply diversity, working very closely with our procurement team to ensure we are partnering with minority and women-owned businesses. And lastly, our CATS Institute for Women's Health. How are we working to establish innovative ways of delivering healthcare for our female populations? And we do this with our strategic partners that you can see listed below these pillars. And we thank them for all of their amazing work and how they contribute to the various programs that we have at Northwell Health. Next slide, please. National Minority Health Month 2020. So the HHS, Office of Minority Health, better known as OMH, has been working closely with the Office of Disease Prevention and Health Promotion over the past several years to ensure that organizations are advocating for our communities, specifically around this time. Now, previously, for the second consecutive year, the theme for National Minority Health Month is active and healthy. And as we continue to move through the COVID-19 pandemic, we're learning more and more the importance of overall health and wellness to ensure that our communities are adopting lifestyles that will support them and guide them through this time. As you can see, we've provided you with the website link. We do encourage you to take a look at their website and learn more about what they are doing in the midst of the COVID-19 pandemic. Next slide, please. And so with that, it is my esteemed honor and privilege to introduce to everyone Dr. Raju, and I will read a piece of his amazing bio that I had the privilege of reading through to provide some of you who may not be as familiar with the work that he has done within Northwell Health and even beyond Northwell Health. Raju, MD, combines his executive leadership experience in healthcare with a deep commitment to achieving social equity to improve the health of communities in need. As Senior Vice President and Community Health Investment Officer, he evaluates the needs of Northwell's most vulnerable communities and provides solutions for them by collaborating with community-based organizations. He's responsible for promoting, sustaining, and advancing an environment that supports equity and diversity and helping the health system eliminate health disparities. Prior to Northwell, Dr. Raju served as president and CEO of NYC Health and Hospitals from January 2014 through November 2016. Dr. Raju has also served as CEO for the Cook County Health and Hospital System in Chicago, the nation's third largest public health system. His medical career began at Lutheran Medical Center in Brooklyn, and he later served as Chief Operating Officer and Medical Director at NYC Health and Hospitals Coney Island Hospital. In 2006, Dr. Raju became the HHC Chief Medical Officer, Corporate Chief Operating Officer, and Executive Vice President. Under his leadership, HHC continued to improve health quality, patient safety, and healthcare data transparency. Dr. Raju served as Vice Chair of the Greater New York Hospital Association and currently sits on the boards of numerous city, state, and national healthcare organizations, including the American Hospital Association, the New York Academy of Medicine, and the Asian Healthcare Leaders Association. Among his numerous awards and accolades, Dr. Raju was selected to Modern Healthcare's 100 Most Influential People in Healthcare. Modern Healthcare also named him one of the top 25 minority executives in healthcare and one of the 50 most influential physician executives in healthcare. Dr. Raju earned a medical diploma and Master of Surgery from Madras Medical College in India. He underwent further training in England, where he was elected as a Fellow of the Royal College of Surgeons. He later received an MBA from the University of Tennessee and CPE from the American College of Physician Executive. Dr. Raju, thank you so much for taking the time to spend this afternoon with us.
Thank you, Andrea. Thank you for a very generous and kind introduction. Again, I just wanted to take this opportunity to thank the Northwell, which has been a wonderful organization, and it shows every single day. But all of you who are in the call, as well as the people who are taking care of patients right now, really putting yourself in the front line, risking yourself and taking care of patients. So the Northwell really lived up to the credo as one of the best healthcare delivery system in the world, and you live it each and every day. And I really want to thank you from the bottom of my heart for the incredible work you guys do each and every day, and so many lives you've saved from this pandemic, which is really sweeping across the country. So it's more than 18 years since I made the transition from a lucrative academic surgical career to looking at the healthcare disparities. And the healthcare disparities still remains in this country. So we have worked on the last 18 years on the various aspects of why the healthcare is so different, why the zip code makes a determination how long you live, why somebody who happens to be in the south side of Chicago dies 17 years earlier than if he is somebody in the north side of Chicago, why somebody in Bronx, South Bronx, dies 14 years earlier than somebody who lives on the Upper West Side. These concerns always bothered us for many, many years. And we looked at it through different lenses, and then we found out that the major portion of it, in addition to their minority status, in not only in the racially, ethnically, their minority status is not having enough lack of immigration, lack of access to healthcare, lack of insurance, lack of transportation, so many issues which we finally branded as social determinants of health and some of the people want to be more positive. They call them health drivers of health. So people who have been in the journey for the long time, we always feared something like COVID-19, which will hitting a country and the world. Because normally these people who are minorities, they live in a very precarious health system in the country. They really do not have the access or the outcomes the other people have. And in a pandemic, it becomes extremely difficult. Though the people call this pandemic as a great equalizer, that means it affects everybody the same way. It is really not true. It may affect people the right way, but the people outcomes are so different. So we go to the next slide. So somewhere in February, me and our team members, we sat down and we were started looking at this, how will a COVID-19 pandemic will affect the minority communities and the people who are socially vulnerable. There's a lot of talk at the time talking about medical vulnerability. The people who are older, people have immune compromised, people who have pre-existing lung diseases and diabetes, they are high risk. But one of the things which you never talked about was there are people who are socially vulnerable, are as important as more vulnerable than the people who are medically vulnerable. So the first one, so we started kind of raising an alarm. Northwell is probably one of the first systems started raising the alarm saying that, look, if something happens, the people who are minorities will be more affected. They will have more bad outcomes compared to the majority of the population. And the first eye opener came in the New York Times article when we looked at the Wuhan province, of looking at when they completely closed off the province and figuring out, trying to contain the disease. It has become very apparent in the Wuhan province, the people who have got resources, people who have power, people who have the literacy, people who had help, they fared much, much better than the people who didn't have any of those things. People who are poor, people who are illiterate, people who couldn't afford it, they died right in that province compared to the people who are able to afford them. So we started raising the alarm that the similar thing will happen here. So next slide, please. Then it became, everybody started understanding. We are the first ones started talking about, yes, medically vulnerability is an important factor. We need to protect medically vulnerable people, but we also have to pay attention to socially vulnerable people. Then there is this whole avalanche of press reports all over the country, and people have started talking about sometime in April that though it is equalizer in attacking the various people, rich, poor, educated, not educated, people with insurance, without insurance, or people white and black and Asians and Hispanics, but the outcomes are going to be very, very different. So there is just a collage of all the various articles which started appearing all across the country, highlighting some of the social inequities and how different people are affected differently, not necessarily of the disease, because of the existing social conditions. So next slide, please. So I just want to show you three important slides because it becomes like it also became a national outcry. People started saying, wait a minute, we started talking about how many people died, how many people are hospitalized, but we have to tell us how many of them happen to be minorities, how many of them are black, how many of them are Hispanics, how many of them are Asians, how many of them are Native Indians. What is their mortality rate compared to them? What is their rate of going on a respirator? What are their rate of intubation? What is their rate of discharge successfully well treated? So those data became very sparse, and there is a lot of people are asking for the data. And with the result that a few days ago, Andrew Cuomo, the New York governor, basically said that Northwell, as well as the SUNY in Albany, will study the disparities in the coronavirus outcomes on the minority population. So I just want to show the three slides. One is by Anthony Fauci, who basically talked about the same thing in the White House report. So can you just run that first video of Anthony Fauci? We don't hear the sound. Okay. Is there a problem with the sound?
Give me 1 second. I'll get that back up for you.
Okay.
I just want to make a brief comment to get back to the discussion about the health disparities in the African American community, because it really is very important. And the reason I want to bring it up, because I couldn't help sitting there reflecting about sometimes when you're in the middle of a crisis like we are now with the coronavirus, it really does have ultimately shine a very bright light on some of the real weaknesses and foibles in our society. And as some of you know, the greater proportion of my professional career has been defined by HIV/AIDS. And if you go back then, during that period of time when there was extraordinary stigma, particularly against the gay community, and it was only when the world realized how the gay community responded to this outbreak with incredible courage and dignity and strength and activism, that I think that really changed some of the stigma against the gay community, very much so. I see a similarity here because health disparities have always existed for the African American community. But here again, with the crisis, how it's shining a bright light on how unacceptable that is. Because yet again, when you have a situation like the coronavirus, they are suffering disproportionately, as Dr. Berg said correctly. It's not that they're getting infected more often, is that when they do get infected, their underlying medical conditions, the diabetes, the hypertension, the obesity, the asthma, those are the kind that wind them up in the ICU and ultimately give them a higher death rate. So when all this is over, and as we've said, it will end. We will get over coronavirus, but there will still be health disparities, which we...
Surgeon General.
Okay.
At the president's direction, yesterday I met with 2,000 Hispanic leaders from their communities, and today the vice president led a phone call that I was on with hundreds of African American leaders, including the Reverend Jesse Jackson, including Derek Johnson of the NAACP, including the National Medical Association and the Black Nurses Association, to talk about some of the alarming trends we're observing regarding the impact of COVID-19 on communities of color. And you've heard the stats in New York City. Hispanics represent the majority of deaths. In Milwaukee County, blacks are 25% of the population, but almost 50% of the cases and 75% of the deaths. So what's going on? Well, it's alarming, but it's not surprising that people of color have a greater burden of chronic health conditions. African Americans and Native Americans, develop high blood pressure at much younger ages. It's less likely to be under control and does greater harm to their organs. Puerto Ricans have higher rates of asthma, and black boys are 3 times as likely to die of asthma as their white counterparts.
Sorry?
Senator Martinez from Suffolk County.
Okay.
On local perspective.
Gross numbers.
You know, we're trying to get the message out there to the communities to please do the best that they can to remain indoors, to not have the contact with individuals. But like I said to you once before, these communities that you mentioned are hardworking communities, and all communities are hardworking. But these individuals are literally on the front line. They are considered our essential workers. They are the ones who are out there in order for us to be able to continue the services that we need in order for us to live.
In looking at the data, there seems to be a correlation between the Latino Hispanic population, the other factors that come into play, high Latino Hispanic population, larger than average household size. So the average household size in Suffolk County is 3, but in these communities, it goes from like 3.2 to 4.8. Some percentage below the poverty level.
These communities, regardless of what their racial makeup is, it's something that we also need to take into account, right? So if we are not doing our due diligence, and by we, I am talking about all levels of government. If we are not putting the information out there in preferred language that is for those specific communities, and we are failing them.
So the question is, this is, yes, the minority communities have got more disease burden. But the fact, what we are trying to say is not only because of that, that may be a factor, but it's also the access to the various things for the minority communities is much less. When we talk about social distancing, it is almost impossible. If you have to go to work and make the money, you cannot social distance yourself in a subway. You don't have that luxury of driving in a car by yourself and able to deal with that. If you live in a public housing where you live on the 14th floor, you cannot social distance yourself in the elevators. So the concept is that somehow everybody has got an opportunity to do what we ask them to do. It is something, it's kind of really a miscast of what is happening around the world. Yes, minorities do have a lot of health issues because of neglected healthcare decisions which our country made for so many years. That's why the disparities are so prevalent. That's why the zip code makes the determination of how long you live and when you die. Compared to that, the social issues are also making a big difference. Next slide, please. So there are a couple of things happening. The devastating impact on the most vulnerable is due to unequal access. Right? These are the two pictures which shows you well. If you happen to live in a little bit better community, you are able to get the coronavirus testing done in a car. You sit in a car, you probably have music going on. You sit down, you watch your cell phone, and you get your things done. If you do not have that, you crowd in front of the public hospital. This is the second picture on your right, is in front of a public hospital system in Queens, where you stand, wait in line. These are the people who are supposed to be tested. These are not the people who are really worried well. These are the people who are sick, who've been sick and having fever. They're waiting to get tested. And they're getting tested. As they're being tested, they cannot socially distance themselves because this is the true state of affairs. This picture tells you 1,000 words regarding accessibility to the test, the accessibility to the treatment. If you happen to live in a nice neighborhood and have a transportation, you are much better safe, much better protected compared to somebody who don't have a car. You just sit down and you probably, even the people, some of them who didn't have the coronavirus, probably would have got it by the time they went home because they have been standing outside a line to get the testing done. Then also this has become a big issue because some of the people who are really, the more influential people, some of the Hollywood stars, some of the NBA players, they all got tested, even though they are not symptomatic. But to get tested, for a person in New York City, New York State, as well as in the rest of the country, you got to be sick. And you got to be sick enough to be almost ready to be admitted to the hospital so they can get a test. So the unequal access is a major, major factor. It is a factor in the normal day-to-day living, but it became a bigger factor when there is a pandemic sweeps across the country. The economic problem, right? These are people who live from day-to-day wages. When they don't have the money, they have no money to buy anything. Even though the federal money will come to you eventually, right? It takes a few weeks. These people really suffer from lack of food, lack of money, and they're not able to. They live from day to day on a daily basis. So the economic problem are compounded in this population because they do not have the reserve normal people have in the bank account, which they can actually dip into to protect themselves. The social isolation is a major factor because these are the people who really they always live in the shadows of the society. They have a tremendous amount of social stress factor, and the social isolation of these people because of what we call as stay inside the house. We have a devastating mental health issues for this population. And the alcohol and substance abuse, which is more prevalent in some of the populations, because of lack of ability to have meetings with the with the AA, Alcohol Anonymous, as well as the Narcotic Anonymous, will basically makes the people, go back onto the way when they are in the recovery and rehabilitation. The last but not the least is the food insecurity. So these people who don't have money to buy food in the normal times, now that they don't have a job, they don't have money, they're basically living on a starvation level. even though the government is trying to find some food banks and trying to do that, some of you saw the lines in front of those food pantries. It goes on for 2 miles before you can get food for you. So these are all the impacts. So as we talk about medically vulnerable, we have to talk about socially vulnerable. The minority communities are disproportionately affected by this epidemic than the majority population. We should not just say that that is because the minorities have got more health issues. It's true. Yes, they do have health issues because that is because of the neglect of these people by the healthcare delivery system in our country for the last 50 years. But they also have other social issues which prevents them from getting the outcomes they deserve to get. Next slide, please. So what is Northwell doing about it, right? Northwell, we have been working on a platform for many months. This is because of on the health literacy side and the food as health. So basically, we started asking patients, right, the COVID patients, 2 questions on the food insecurity. The question is there on the right-hand side, the last 12 months, very worried about food being run out before you get money to buy more, or the last 12 months, you bought just enough and didn't have enough money to buy more. If you have them positive, then we connect them to the appropriate food pantries and organization trying to address some of their food insecure issues. As you probably know, we have really addressed the food insecurity on the peace times, on the regular times, by having the food pharmacy actually in 2 of our hospital systems right now. In South Side has got one, right, and we are trying to do that in all across systems so that we are able to encourage people getting healthy foods. So we are basically focusing on the people when they get discharged. We want to make sure that they have enough food to eat when they go home, and that is unique to Northwell, that we are not only take care of the health issues, we also focus on their food insecurity issues. Next slide, please. A major factor, right? One of the other major factors in the disease as the ability and the bad outcomes and disparities in the outcomes of disease is due to health literacy. With all due respects to the enormous amount of work being done by the various leaders in this country, to watch their press conferences and learn from them, you need to have at least a master's degree. And you need to know English, so you're able to follow with that. Even though some people just say a few words in Spanish at the end of the day. But we have been working on health literacy for a long period of time. One of our leaders, Sabina Zach, has worked on it with an organization called a company called creating a chatbot, which basically able to give the information to the patients at their literacy level through their smartphones and their language, and they can be able to adjust the same message to the literacy level and language and be able to do that. We have been doing some pilot studies with that regarding our colonoscopy patients, and we are seeing some initially good results. Now we actually added that to the COVID related education, so that we are also working with the local community-based organization to spread the education, what social distancing means, how do you wash your hands, how do you cough, how do you wear your mask correctly. All those things has got to be done. So health literacy is a major component of dealing with that. So the health literacy cannot be delivered purely through a television on a half-an-hour show in English. It has got to be done the literacy level and the language. So Northwell has really taken the health literacy initiative as a great step forward and trying to incorporate the health literacy into the day-to-day education of our patients. And we are very proud of what Northwell is doing on this in this particular area. Next slide, please. We actually started looking at the social vulnerability of the patients and communities, as a part of one of our major focus of our group. And our team with Stephanie Cobo actually working on creating a social risk score index. And we also working with the NOWPOW, which is a community resource guide, to direct the patients whom we identified as high risk for social issues and able to combine both medical and social issues and taking care of them at the same time. Now with this pandemic coming in there, we started using the NowPow, which is a local community resource guide. It basically tells you zip code by zip code by the various social determinants. In other words, who is producing the food pantry, who is in charge of transportation, who do you approach if you have a homeless issue, who are the right people for that. Those kind of things are available in NowPow. So now we are using NowPow, expanded use of NowPow very quickly and fast-tracked it, the rollout, so that we have our internal people who deal with the patient discharges and the transition care are using them to refer them of the appropriate community-based organization using NowPow. And we are also rolled it out to the community-based organizations so that they can also identify some of the social issues and refer them to other community-based organizations. For example, if somebody goes to an organization looking for a transportation needs, then they also have food insecurity. Then that community-based organization using the NAPA, which we funded, to refer them to another community-based organization without touching our system. So we have done some very innovative things of taking care of and addressing some of the social issues. And Northwell should be very proud of that, because we, as a pandemic racing through this country and the New York City and the state, we are also focusing on not only giving the best possible treatment for them and the most innovative treatment. We got the best lab, to create the test for us. On the top of it, we also are able to address the social needs of the patients at the time of this pandemic. Next slide. So again, I want to close by saying a big thank you. Thank you. Thank you for what you do. Thank you for a great system which takes care of people, which really puts itself at risk to take care of patients. Northwell really lived up to its name as the best healthcare delivery system in the world. Thank you.
Thank you so much, Dr. Raju. All of this information was extremely helpful, just in terms of understanding Northwell's, collection of this information, learning more about what services and resources are being provided to our communities, and how we are incorporating all of this data into our strategic plan to combat this pandemic. So we really appreciate all of the information that was just shared. Next slide, please. So at this time, let's transition a little bit into our discussion. So for my first question, Dr. Raju, and thank you again, you definitely shed a lot of light around many of the social and economic factors that present challenges on how not only Northwell, but healthcare systems around the country are able to provide treatment and how we're taking steps to eliminate them. So when we look at the health literacy programs that you referenced and the community resources that we are actively developing and distributing into our diverse communities, how are some other ways that you see us improving health equity, specifically within our underserved minority communities across our territories?
So I always said for a long time that if you want to improve the health equity in this country, you got to improve the social equity. The social equity and the empowerment is as important to creating health equity. So health equity cannot be improved in isolation. You can do a lot of projects, but the fact of the matter is, I've been in the journey for over close to 20 years, and I always see only marginal improvements in health equity in this country. So the first aspect is that we need to really get involved in the social equity. The second aspect of it is, right, we have to really empower the communities. So what we need to do is we have to, instead of looking at the communities through the Northwell lens, we need to look at the Northwell through the community lens. Then the different picture emerges. Because we tend to, all the healthcare delivery system tend to really have projects what they think is a good thing for the community, and we need to really, we change that model in Northwell. We basically asking the communities, please tell me what is the major need. You'll be very surprised. Some communities, will be involved in, I want public safety. Some communities say, I need transportation. I want it to work with. Some of them are really not healthcare, but they are related to healthcare. It's a social determinants which affects the outcomes of healthcare. So we have to learn to work with the different not-for-profit, different community-based organization, different government agencies, and trying to create a holistic way of empowering communities so that they attain the social equity. And the social equity will lead to health equity eventually.
Absolutely. Thank you. Over the past, I'd say about maybe a week and a half or so, or depending how frequently our Northwell team members have been following the news and following a lot of the data that's been published, right? And I always say that data without context can be very, very dangerous, because without that understanding and seeing the holistic view of what's going on, we could potentially misinterpret the data, right? And cause even more fear, a heightened awareness. So over the past week or so, we've seen the numbers specifically in Long Island communities such as Amityville, Wyandanch, Hempstead, and Central Islip. And we're seeing these alarming positive cases of COVID-19 in these disenfranchised areas. How are we as a health system currently addressing COVID-19, specifically where we're seeing these numbers increase?
So I think a couple of things. One is, right, when they come to us, we give them the best possible care. In fact, our care is extraordinary, and which will rival any other systems healthcare, because we have some of the best, healthcare providers in the country working with us. But the second part of it, we're also reaching up to those afflicted communities and trying to improve the health literacy. We talked about it, right? We need to really appreciate and understand why there is a problem. Do they understand what it means, right? Do they understand exactly how to do social distancing? Do they understand, right, how to cough? When you cough, how do you protect yourself as well as other people from disseminating germs? Do we understand, right, what it means to wear a protective mask? Does it, what it means, where is access available? When will you go and call a doctor? And when will you end up in the emergency department? So all those things is a huge part of his health literacy. And we have to really improve the health literacy of the people, right? Because these are tough times. Normally, we kind of disperse this knowledge through the community-based organizations, but because of the shelter in, a lot of community-based organizations are not functioning to the full capacity as it usually is. So that is also a challenge for us. So we need to do that. Second thing is, as a medical doctors, try to manage the health conditions and also follow up, we are working with the local communities and local organization, trying to understand their needs, which are social needs, like food, like the social isolation, or the literacy effect, or the transportation needs. We are trying to figure out how do we help them to get to the doctors and get to do the follow-up and making sure that they live a very safe way of taking care of themselves. So that's what we have been doing, and that's what we need to do more of those things. And we need to focus on those areas you mentioned, because the data is so vital. Because we, instead of just doing it, boiling the ocean, we need to focus in on the areas where there is a cluster of these people who really have a large number of people who are really getting afflicted. We need to focus in our attention on them.
Absolutely. Thank you so much. And I know you had mentioned during the presentation that we already knew that many of these disparities existed, and it didn't necessarily take this pandemic to shed the light. But I think this also creates an opportunity for many of our community-based organizations, also many of our faith-based organizations, to take inventory and to really identify those areas where perhaps the efforts weren't as prioritized in the past, and hopefully moving forward, developing a more strengthened, more synergy approach where we can all work collaboratively to address that. So thank you so much for that.
No, it has been very effective, because Northwell, with these health solutions, your team of Institute for Diversity, as well as community relations, community benefit programs, Eddie Fraser's group, all of them are worked very hard. So many during the peacetime, trying to create the community connection. And that is very, very effective. So this is really a very collaborative way of addressing the community needs. And we have worked very well together. All of you deserve a lot of credit in building the building blocks of getting the community support and the trust, which is so important to do that. So it is easier to build on that when you already have a system which has got, which is trusted in the communities where we are. It makes our life much easier.
Absolutely. You briefly touched upon this during the discussion when you talked about public housing. And, we've been seeing a lot around the policies and recommendations to flatten the curve are oftentimes not so realistic for minority communities, right? So for example, physicians upon discharge, they're instructing our patients to self-quarantine for 7 to 14 days, use separate bathrooms, kitchens, and sleep in separate rooms. And yet it's unrealistic for a typical family of 3+ individuals who live in a 1-bedroom apartment. So how can we start to make our clinical recommendations more inclusive and culturally responsive?
Which is, we have been talking about that for the last 4 or 5 weeks, when the people start telling people, saying that you have to really do that. And somehow, if you don't do that, you are not a good citizen, right? And that kind of are unfortunate, because people are not bad people. They couldn't do it because they don't have the money or the space or the wherewithal to get it done. Finally, there are some healthcare institutions, including New York City, started saying, okay, the people who are getting discharged who need to self-quarantine themselves, maybe we need to use the hotel rooms, right, and put them there 14 days, making sure that they are able to manage that, right? That is just starting. That's the whole concept of it. So it is basically, what it shows is that first of all, we are not prepared for such a devastating pandemic, which is all true. Yes, absolutely. This is even in the normal days, we are not prepared. But we are also not prepared how to take care of the socially vulnerable communities, because they are in the normal day, they are already, behind the 8 ball, right? Now, on a day like this, when the resources get constrained, when the tests are minimal, when the capacity of the healthcare delivery system are stretched, the people who really get affected or more affected are the people who don't have the wherewithal to manage in a normal day. So you're right. That's why we have to be very, very careful when we tell them just to do this and do this. We assume that they are going to do it. But the problem is, some of them want to do it, but they cannot do it because they do not have that kind of resources to get it done.
Absolutely. Thank you. And my last question for you, Dr. Raju, after, and again, thank you, because I know that your team and just how all of the services you're providing and how much of a collaboration you all are advocating for with our community partners and with our internal partners. We're learning so much as a health system. As you just mentioned, we're all learning so much of this around this as healthcare professionals. So when you are able to periodically just kind of take inventory of all of the new information that's becoming available and the new strategies and ideas that are coming out, what do you hope will change when this pandemic is over, both from a healthcare industry standpoint and also from a community lens?
One of the things which highlighted, we have been, some of us, like, who have been in the field for a long time, we have been kind of waving the flag for a long period of time that there is a huge healthcare disparity exist in this country, and the health equity is the social equity is important to develop as a part of the organizations, which work in that space. But because once this becomes so obvious over a period of time, in the future will be that a lot of people may follow our model of taking care of the patient holistically, because we understood in our system that only 20% of your outcomes in health depended on the clinical care. 80% are non-clinical care, and 40% of the 80% is due to the socioeconomic and environmental factors. And the other 40% is due to healthy behaviors, which is basically health literacy, right? And we are the first one to differentiate between health literacy and patient education. Education is very different from literacy. And we are able to demonstrate that health literacy does improve, the outcomes of the patients in our pilot studies. So we will probably launch on and go on to improve what we are doing now and trying to identify the social risk factors, which Stephanie Kubo's work of identifying and classifying patients based on not only their medical risk, also the social risk, and also connecting the various community-based organizations with the health solutions have done a good job of through their disrupt and trying to refer them to appropriate areas to get that done, and build on the community trust factor which your team as well as Eddie Fraser's team have developed over a period of time, and trying to build on the community trust. All these things will take an accelerated pathway so that we will try to treat patients holistically. We will not just treat the disease, we will treat them, the patients themselves. So that is unfortunately, healthcare delivery system moved so far away. We know more about somebody diabetes than about themselves, right? We know diabetes of John, but we know is diabetes better than knowing John, and we know almost next to nothing where John lives and how he lives. So we sometimes give them instructions to get it done, but unfortunately they can't get it done because they live in a food desert. They cannot get to the food you want them to eat. But what we have done for so many years across the country is we always compensated the social factors with more medications. Whenever we found the diabetes not under control, not because our medications are ineffective or inadequate, it is because they are not able to follow the food regimen because they happen to live in a food desert where there is no grocery store available in the 5-mile radius. And they only have fast food restaurants available next door. And we tend to compensate that by increasing more medications to control the blood sugar levels. So we have, as a system, identified that, and we are really working very hard to, not to treat the social issues with more medications. So we are one of the first systems in the country trying to do that, raise awareness. So we'll continue to do that. We'll continue to develop that. Northwell will be the first system which will take care of, assess a patient, both social risk and medical risk. And as a great healthcare providers are taking care of the medical factors, the great work you guys are doing will also take care of the social risk factors so that we will be able to give them a better outcomes than other delivery systems can. So this has been an exciting work with a lot of great people working together to make this happen. But this will, because of what we have learned in this unfortunate pandemic, our eyes are widened up more, and our hearts are opened up more, and we will definitely deal with them much more effectively than we ever dealt with them.
Absolutely. Thank you so much. And Dr. Raju, I am going to throw in one more question. With all of the work that you're doing and just the constant changing of strategy and constant shifting, what's one thing that you're doing for yourself just to check in and maintain that balance and harmony within your life and for your family?
No, as I said, I am blessed because I do have a great family, great team to work with, and I am not really as much financially constrained as the people we are trying to serve. So we are doing this balancing act for a period of time, but this is something I'm very passionate about because we have not health equity means it's for everybody. We cannot just improve the health of one group of people at the expense of other people. I'm not saying people do it wantonly or doing it purposely, but we have not really looked into that. In fact, we were, Mark, Jared, and me had a conversation a while ago, and we were actually kind of, agreeing upon some. When we talk about how well we control diabetes, sometimes, if we dwell deep into one level and see, okay, we control. Our control of diabetic rate is 80% in this particular area. So we need to know, is it 80% is a aggregate of every ethnicity, or it is like only 20% black and 90% white, because the averages always make you lose perspective, which you have to dwell into. Because every data we have, we need to dwell into the data and see is there a discrepancy between the various minority communities. So sometimes the big figures will kind of mask the underlying different vulnerable communities, because overall we are doing well, but we are not doing well in different communities. But Northwell and Mark Jarrett has actually started looking into that in a couple of years ago. So I was very impressed with that, because that is so important to us, that we just not only get the good scores, we also want to make sure that everybody gets a good score. And that has been a great factor. So I am very happy, and in the sense that finally eyes are getting opened up, people are looking at it, and people start to appreciate what we have been talking about for many, many years. Because, as I used to say, in 2000, the first decade of this century, in 2010, 9, 14, people never even talked about social determinants of health. That was not even in the vocabulary. But now there is more and more awareness of that. So I am happy about that. I'm not happy about the pandemic, but I'm very happy about the people's eyes are open and they start looking at it differently, not only a human body as a machine with the various parts and try to fix them. We also understood that where they live and how they live has got a greater impact on the longevity than just a disease they live with.
Absolutely. Thank you so much. And for all of our team members who are in attendance, thank you so much for submitting your questions. I did want to take a moment to acknowledge them in the chat. We will be compiling those questions and sharing them with Dr. Raju's team, and we'll work with them to provide updates for all of your inquiries. So thank you so much for being engaged in the discussion. Next slide, please. And with that, I would like to again thank Dr. Raju and the community health team for stepping away from your day-to-day and having this very important and very informative discussion with us to recognize Minority Health Month. We truly appreciate it, and we appreciate your leadership, and we send you positive vibes and great energy as you continue to not only educate, but also to lead the charge in space of diversity, inclusion, health literacy, health equity, in partnership with our team. So thank you so much.
Pleasure's mine. Thank
I would
you,
also like to
stay very safe. Stay very safe.
Thank you so much. You as well. I would also like to take this time to thank Dr. Jennifer Merez, who is my SVP and Chief Diversity and Inclusion Officer, and the Center for Equity of Team for the opportunity to moderate today's discussion. And last, but certainly not least, thank you all to our attendees, to our board members, and our leaders around the health system who joined us this afternoon and spent some time to acknowledge National Minority Health Month. Please continue to stay safe. We are currently working on a number of virtual sessions and opportunities for us to keep you all engaged and keep you all informed. So you can expect to see more invites for our Berg Coffee Chat series, where we will be partnering with many internal stakeholders to provide information around resources available to yourselves and to your loved ones. You can also expect to see more of our mental health virtual sessions in partnership with our Berg members and our corporate wellness partners. And lastly, interactive professional development workshops. So it is important for us to continue to invest in ourselves and to step away from many of our responsibilities and the hats that we're currently wearing to ensure that we're building skills and expertise in various areas as it relates to our health system. So again, thank you all for spending some time with us today. Please continue to stay safe, and we look forward to your participation in future events. Thank you.